Good evening, friends and colleagues. Welcome to our month-to-month Riverside County Public Health Officer Physician-to-Physician webinar. Dr. Luang was indisposed today, so in his place, we have Dr. Jennifer Chevinsky, who is the Deputy Public Health Officer. Dr. Chevinsky is the Deputy Public Health Officer for Riverside County Public Health. She recently joined RUHS after working for the CDC as an Epidemic Intelligence Service Officer for over 2 years. While at CDC, she participated in multiple deployments for the COVID pandemic and was the lead author for the CDC's interim guidance on post-COVID conditions, also known as long COVID. She completed her undergraduate medical education at University of South Florida, Mount Sinai College of Medicine, her internship at Lehigh Valley Health Network, and her specialty residency training in preventive medicine, as well as master's degree in public health at Loma Linda University Medical Center, where she also rotated through Riverside County Public Health as a resident physician. At RUHS Public Health, Dr. Chevinsky serves as the TB controller, treating patients with tuberculosis throughout the county and oversees communicable diseases and the public health laboratory. Dr. Chevinsky, welcome to our monthly talk and webinar. With your introduction and update about the county COVID situation, and then we'll go to questions.
Well, thank you. Thank you for having me here. I did want to provide a couple of updates. So a couple of those that also relate to some new approvals to make sure that everybody's aware. And I'll provide some links from this update, and then also for the responses to the questions with the information, the studies in the chat once we complete the question and answers. But for those updates, one thing that I wanted to bring to the attention of everybody here is that monoclonal antibodies, there has now been FDA approval for one of the combinations, the BAM-EDI, to be able to be provided to all ages. So that's newborn and up. Previously, it was only the monoclonal antibodies were only available for 12 and up and over the age and over 88 pounds, but now there's no weight limit for that BAM-EDI or for or an age limit. So for those at high risk, talking newborns, those under the age of 1, younger children with chronic health conditions that might be higher risk to get severe disease if they have COVID, there's now a monoclonal antibody option for them. Today, there is actually news that came out about FDA approval and CDC recommendations around boosters opening up for 16 and 17-year-olds. So we anticipate that that could start as early as tomorrow. And also there's been some recent information in about a new monoclonal antibody that's been approved for pre-exposure prophylaxis. And that's for high risk or immunocompromised groups. That's the Evusheld put out by AstraZeneca. And so that's still making its way through the federal and state allocation chain. But that would be used for pre-exposure prophylaxis in highest risk groups that are immunocompromised prior to any kind of exposure, but as a form of protection for them in case they were at some point to come in contact with COVID. We continue to work on increasing our numbers around boosters, as well as vaccination in the pediatric community as well. And so one of the questions goes to that specifically, so I can talk more about the vaccine numbers at that time. But thank you for having me, and I look forward to talking with all of you and hearing your questions about these and other topics.
Dr. Chevinsky, so though the Omicron variant appears to be highly transmissible, early reports are that it is not causing severe illness. Is this because most detected cases we've been hearing about are breakthrough cases of the vaccinated who would be more resistant to severe illness? Is there any data from South Africa that validates the Omicron infections are not as severe as on the unvaccinated? And has Omicron been detected in Riverside County?
Thank you. So that's a multi-part question, and I'll walk through each of those different parts. If we take a step back, though, about how this came about, how we found out about Omicron, and then I'll walk through some of the numbers with you all as to where the information has come from for the thought that it is mild, and some I guess caution in how we look at Omicron and the severity. So first off, as we all know, first detected in South Africa, and that was because they started to see an exponential rise in COVID cases. So back on November 29th, they were seeing less than 1,000 cases per day. As they reached up to December 3rd, they started to see over 3,000 cases per day. And so from the time of November 29th through December 3rd, they saw by that time around 10,000 cases, which was much higher than the case rate that they had been seeing prior. Accompanying that, they also started to see a rise in COVID hospitalizations. So I'm going to send here in the chat. These are kind of like the citations for the different studies. So that way you can look them up too afterwards if you're interested in digging more through the data. But initially what they started to see is there was also a sharp rise in COVID hospitalizations. So there's an initial study that came out of South Africa, not peer reviewed, but just sort of looking at that hospitalization data and looking at what the makeup of those patients were and the severity. And what they found was that in many instances that COVID was an incidental finding for those that were admitted for other reasons. And that additionally, the majority of the patients that were in the COVID wards, they weren't oxygen dependent, which was atypical compared to the previous waves that they were seeing, where the majority of patients were at least on nasal oxygen. So looking at one of the particular hospitals in that region where they had 166 COVID patients admitted, they saw that actually the highest number of admissions was in the age group of 30 to 39 years. Again, much younger than what they've been seeing in previous waves. And that group, that highest number, made up around 28% of their total admissions, and 80% of admissions were below the age of 50. So this is, on a whole, they're seeing a younger group that was in the hospital compared to what they had seen in the previous waves. One of the indicators that they were looking at in terms of severity was looking at in-hospital death rate. And what they found was, of those 166 COVID patients that were admitted, there was 10 deaths over that initial period, for that initial couple of weeks. That's 6.6% of that initial group. And so the deaths that they saw, 4 of those were in ages 26 to 36. 5 deaths were in adults over 60. There was 1 death in a child, but the cause of death was ruled unrelated to COVID. And there were no other deaths in the 34 admissions in the pediatric COVID wards. So in that initial look at the data, they remarked that the death rate of 6.6% was far lower than the overall in-hospital death rate of 23% that they had been seeing over the country for the previous waves. And they also noticed that overall there was an absence in significant increase in hospital deaths, particularly in compared to the dramatic rise in cases that they were seeing in the province. Though they mentioned that part of that might be due to a lag in deaths, and I imagine that's what we're all thinking is part of that we might see deaths to follow in the coming weeks that might give us more information about maybe higher severity than what we are initially seeing in the data. Another point that I think that is fair to consider is the level of vaccination in that community over time compared to the previous waves. The level of vaccination, of course, would be higher during this, Omicron variant wave compared to what it might have been in the previous ones where vaccinations were less available. They also looked at other markers for severity, like looking at ICU, number of patients in ICU, and then the oxygen requirements, the length of stay in the hospitals. And what they found out of those 166 patients is that only 2 patients were in the ICU, neither of them that had a primary diagnosis of COVID pneumonia. And they had 63 patients that were admitted to high care, but the majority of those were also there for a diagnosis other than COVID. And overall, there were shorter lengths of stay compared to the previous waves. So from that, the conclusions that they were drawing was that the majority of hospital admissions were really for diagnoses unrelated to COVID, and that the SARS-CoV-2 positivity was really driven primarily by the hospital policy that required testing for all patients, that they were finding this more as an incidental finding rather than a marker of severity of COVID-19. And so their conclusion then from that is that this exponential increase in the positivity rate in the hospitalized patients wasn't that they were seeing an increase in COVID-19 causing hospitalization, but more so just a reflection of the number of cases that were in the general population in totality, and that it was more a marker of the transmissibility or the transmission of Omicron, as we've seen in the news about higher rates of transmission, rather than a marker of severity from illness. But I think a couple things for us to keep in mind about that. One is, as I mentioned earlier, the age profile is different from previous waves. So is it mild only because we're seeing this in younger populations incidentally? And knowing that, even initially the Omicron variant, it was found in young university students in South Africa. And in addition, the population in South Africa is also skewed a bit more young than what we would see here in the US or in Riverside County. And again, the vaccination rate, 57% there for people over the age of 50 had been are vaccinated, and that compares to around 34% to their 18 to 49 year group. So what we might be seeing is a combination of a younger population that perhaps is less vaccinated, that's getting Omicron, but maybe not getting as sick because, as we know, the higher severity is often also seen in these older age groups. So it's not clear yet that for older people, particularly those with underlying conditions, those are not vaccinated, that they would also have mild illness. It's possible that in those groups, we would still see higher levels of severity like we saw in the initial couple waves of COVID with the other variants. So I think that's where there's still that lack of clarity, and where the raw numbers that they're showing doesn't really yet give us the full picture. So from my sense reading the data, I think a healthy bit of skepticism is okay. Realizing that our population looks a little bit different, that it might look different in older populations where there's chronic disease. The data so far looks reassuring in terms of mild illness, but also mild illness in the way that they're defining it, meaning not on oxygen, not hospitalized, not dying, doesn't account for those that might experience other conditions, like, for instance, long COVID that could be debilitating. In terms of whether Omicron has been detected in Riverside County, not yet, but since it's already in Los Angeles and in other areas of California, it's likely just a matter of time before we detect it here as well. And so again, that initial study is, I sent it in the chat, so that way you can look through and also make your conclusions. But to me, when I read it, it does show that the cases that were in that hospitalization, this preliminary data, the data that we are seeing so far does show mild illness, but we haven't really seen what it could do in an unvaccinated population that has older people that have chronic illness.
Thank you. The current batch of COVID-19 vaccines do not appear to be as effective at preventing Omicron variant infection. Do you have any statistics as to current vaccine efficacy for the variant?
Sure. So I have a couple of studies. The first study is out of South Africa, and these are all just preliminary studies. So again, it gives us initial picture, but it doesn't really tell us the full story. The first study is a very small study. It's not peer reviewed. It's also linked in the chat, out of South Africa, and it took blood from 12 people, and all of the subjects were fully vaccinated, not boosted, but they were fully vaccinated. And then also there was some portion of them that also had experienced previous infection. The majority of samples that they looked at were from women between the ages of 40 and 70. And what they found when they looked at these blood samples and they exposed it to the Omicron variant, they saw a 41-fold drop in neutralization in those that were fully vaccinated without prior infection when compared to how the vaccine held up against other previous variants. So this was just looking at Pfizer and looking at the neutralization from the antibodies to the Omicron variant. So they saw that significant 41-fold drop. When they then exposed it, the blood of people that were fully vaccinated who had prior infection, they saw far better neutralization against Omicron. So overall, this study, though again, it's preliminary, only 12 samples, it's not really very large in order to make generalizations. It did hit the media though, and there's been a lot of talk about it. That initial study is starting to show that there might be partial protection from vaccination or from Pfizer in particular, the study was on, but not complete escape. So some level of protection. We could also, and what their conclusion was is that they anticipated that they could see spread among those that are unvaccinated, perhaps a little bit more transmissibility or spread among those that are partially vaccinated, and perhaps even elevated compared to what we've seen previously in those that have been vaccinated but don't have a previous infection or that haven't been boosted. I think one of the, the limitations of this study is that it's really just looking at the B cell immunity and looking at the antibody response. It doesn't take into consideration anything about T cell immunity. And so there might actually be more protection from the cellular immunity on top of what we're already seeing with the antibody protection. Then there was a second study that came out from Pfizer. And so their study was quite a bit larger, and they looked at in their laboratory studies, they compared those that had 3 doses, so the initial 2 primary series plus the booster, and then they also looked at those that had their primary series, the 2 but without the booster, and then they kind of compared the response when exposed to the Omicron variant. And what they showed is that with the booster, it increased the neutralizing antibody titers by 25-fold compared to the 2 doses alone against the Omicron variant. And so in that, when they saw the response, what they actually saw is that when you had the 2 doses plus the booster, that the level of protection is similar to what we would see with completion of a primary series against the other variants. So what they were considering or describing as good protection once we get the 2 vaccines plus a booster against Omicron. They also remarked that 80% of the epitopes in the spike protein that are recognized by the T cells aren't affected by the mutations in the Omicron variant. So it's also likely that those 2 doses may still induce protection against severe disease from the side of the T cell protection, if not necessarily from the B cell antibody protection. And they also noted that they're also working on a variant-specific vaccine for Omicron in case it needs to be used, and it should be that they're anticipating that something like that would be available in March. So what these 2 preliminary studies show, and again, cited in the chat if you want to dig into them a little bit further, is that the Pfizer vaccine seems to have at least some level of protection, and that with the addition of boosters, it seems so far that the protection is actually quite good against the Omicron variant.
Thank you. The next question is the Omicron variant is just one of many forms of COVID-19 that we have seen and will see in months to come. Do you have an estimate as to how close we are to herd immunity, considering natural immunity through past COVID-19 infection and vaccine adoption combined? Is there any new data as to lasting natural immunity and reinfection of those previously testing positive? Is our county actively tracking data on reinfection and breakthrough cases? If so, any insights, please?
Sure. So first talking about the herd immunity component, and it's really difficult to make a judgment on herd immunity and at what point we would reach that with regard to COVID. And in fact, there are many experts that believe herd immunity may not be possible in the same way that we've seen it for other conditions. And just to talk about a little bit more, I'm sure, many people on the call probably already know that herd immunity, we typically look at that. That's when a sufficient proportion of the population is immune to an infectious disease. And typically we can see that either through vaccination or through prior illness. And COVID is a little bit different in that sense, in that one, we're seeing multiple different variants in which having protection against one may not confer protection against the others. And that additionally, the timing of protection may not be as long as what we would hope. So it may provide protection for some shorter window of time, but data is still being collected in terms of how long the immunity window is after somebody would have a previous infection. And there are many things that go into that in terms of the severity of infection that they have, the viral load at the time. So it's really an imprecise measure at this point in order to see what level of protection or immunity somebody has from the prior infection. Another point on this is that that herd immunity, the percent of population that's required to reach herd immunity, it differs based on the disease and the characteristics of the disease. So the more contagious the disease is, the greater the proportion of the population that's needed to be immune in order to stop the spread of disease. So even before Omicron was in the picture, experts were estimating that herd immunity could require around 80 to 90% of the population to have COVID-19 immunity, either through prior infection or vaccination. But again, because immunity wanes over time, we're seeing that from the primary series, which is why we're also recommending the boosters. And then also that imprecise or unclear protection from past infection makes it very difficult to estimate where we are as a county or as a state, as a country when it comes to herd immunity. That said, experts still advocate and say that, vaccines, including boosters, is our best chance at reaching, if it would be possible to reach herd immunity, that would be our best chance at slowing the disease spread. But until then, that's, why we're continuing to talk about masking, hand washing, avoiding crowds, all those other non-pharmaceutical measures. But whether or not herd immunity is actually possible continues to be highly debated. With that, the thought that the way that we perceive herd immunity may have to change as we're thinking about COVID. So there are some experts that believe that complete elimination of the virus is unlikely, and that instead what we would be looking for is having a high enough level of immunity via vaccination and past infection that the disease would just be less severe, so that we would have a reduction of strain on the healthcare system, less healthcare demand, and return us closer to the normal state of affairs, with the idea that there might still be some level of circulating virus at a much more mild level than what we have been experiencing with Delta and previous waves of COVID. That's to say that where we are in herd immunity, it's not so clear, but seeing as we're still at quite low levels of vaccination for kids, we'll talk a little bit more about that later, we're likely still in a place where we have a lot of room to improve with our vaccines and our boosters in order to reach closer to that. And then let me see. So in terms of tracking reinfection, breakthrough cases, that is something that, that we are working to track. I don't have good numbers for you right now, but I can try and get additional numbers to follow up with you on for that. In particular, we're looking for reinfection and breakthrough cases in order to send those samples on for whole genome sequencing, particularly now to try and see whether that's Omicron or what kind of variant that is that's causing it. So the insights that I have to share are that herd immunity is going to be challenging. It may look different than what we have seen in the past, like around measles or polio, for instance. It might be reaching a level of control where we have enough vaccination and boosted community that the disease that we are seeing is fairly mild and just spreading quite a bit less than what we're seeing right now.
Great. Next question. Vaccines have been traditionally administered in pediatric offices. Are most Riverside County pediatric offices now offering the COVID-19 vaccine? What is the current update as to how many Riverside County children have been vaccinated?
Sure. So we're continuing to work with healthcare offices, including pediatric office, to try and increase the number of offices that are giving COVID vaccines. So ideally, we would like to see that they do transition more over into the pediatric clinics, just like we would prefer to see that for the adult and internal medicine, family medicine clinics as well. But in the meantime, while we're getting sort of these huge fluxes as something gets approved, public health has been serving to fill some of those gaps by having these mass vaccination events, understanding that it may take some time until we're able to better transition those services back into the healthcare system. As far as the number of kids that are vaccinated, it's if you compare it to other counties in California or to the state, we are still on the lower side, but we are increasing. And I think also something to recognize here is that we do have a larger proportion of HP1 and HP2 population, so more skewed towards disadvantaged communities than perhaps some other counties that have higher numbers. So right now we're at 5.7% of children between the ages of 5 and 11 who are partially vaccinated, and we're at 4.1% for fully vaccinated. And just to have a comparison point, if you look at the age group right above, so the 12 to 17-year-olds, we're at 49% fully vaccinated for that group. And of course, at each of the age ranges that we go up, we see higher levels of vaccination. So if you look at the 65 plus fully vaccinated, then we're up at 73.6% for that number. So the takeaway from that is that we still have work to do in our youngest populations to try and increase the vaccination for that group.
So total of 5 plus 4, 9% have been vaccinated fully or partially, or total is 5%?
So yeah, so I can tell you, so it's 13,022 people that are in the 5 to 11 age group that are partially vaccinated. So that's the 13,022. And then we have 9,262 that are fully vaccinated.
So total of 22,000.
That's either partial or fully.
Yes. Yes. Is there any different formulation of the vaccine for pediatric population as far as dosing is concerned?
There is. So the pediatric dosing is 1/3 the dose. So it's only Pfizer that's available for the 5 to 11-year-olds. And it's a 1/3 the amount of what an adult dose would be. So it's a much smaller dose.
I see.
Yeah.
I see. Our next question is, lots of questions being asked about mixing and matching vaccines when receiving booster dose. Is there any data that shows about benefit or preference about mixing and matching? Because some patients are coming to offices who are getting Johnson & Johnson, where the primary vaccine, two doses were Pfizer, and Moderna now, which was Pfizer before. Is there any benefit or?
Yeah, so there's been a number of studies that have looked at this, and it's essentially the overall message is that any combination of them will provide high protection. But to go into the weeds a little bit more, because I know that's probably also what you're looking for. And when I have the conversations with my patients, I'm also looking very closely at the data to see what provides the most maximum benefit, right? So essentially in the studies so far, the biggest benefit has been shown for those that initially had a Johnson & Johnson and then get one of the mRNA vaccines. So then if they had initially Johnson & Johnson, then they get either the Moderna or Pfizer, we see quite a boost in immunity compared to any of the other kinds of combinations. And that's in part because the initial just one dose of Johnson & Johnson conferred less immunity to begin with, so that net improvement is higher once they get one of the mRNA vaccines. There isn't really great data to show if you had one of the initial mRNA vaccines. So if you had Pfizer or Moderna, if you pick, say if you had Moderna and then you go on and pick Pfizer, or you had Pfizer and then go pick Moderna, how much of a relative boost, one being more than the other. So in those sorts of situations, typically what when I talk with patients, what I say is, if it is available in the office and they have the same one that they already had. So if they had Moderna and we know that they already tolerate Moderna well, I talk with them about, it's predictable, what the response is, you've already had it, you can consider sticking with the same one. Same thing for, Pfizer, you already had it, the side effect profile to you is familiar, consider sticking with the same one. It's more so, a question of if one or the other is not available. So if they come in and you only have Moderna that day and they had Pfizer, it's safe to say that if they got Moderna or they got Johnson & Johnson or whatever was available there in the office, that would also protect them and provide good protection. So when that statement or those statements from CDC initially came out, I think the intention behind it was such that if somebody's coming into the office, we don't want to turn anybody away, and that any combination that they get is going to provide them protection. But for those that are asking for a little bit more data on it, the one that I think has shown more so that benefit is Johnson plus an mRNA, but all of the other kinds of combinations hasn't shown an overwhelming increased benefit for a mix and match, just similar levels of protection, if that helps.
Thank you all. Thanks, Dr. Chevinsky, for updating us. We really appreciate your attending, and good night and have a safe holidays.